Thank you, Dr. Treppel. Here's a sailor that's solely able to pilot his ship with the aid of a mechanical device known as a manual winch. This fixed rotating drum that's utilized mechanically increases the pull on a line, enabling the skipper to adjust the sails, set the course, and sail his ship smoothly and effectively. In essence, it's the mast and sails that charts the course and sets the speed, much like the superstructure in the human body. So it sets the speed, charts the course. Superstructure allows it to flow freely over an infrastructure or hull. In the human body, we have the rhythmic, cyclical, and symmetrical oscillations of the superstructure to allow it to freely pass over a stable and supportive infrastructure. Defects or deficiencies anywhere in this complex process disturbs its pedal mechanics and increases plantar pressures. So, plantar foot ulcerations are precipitated by pedal pathomechanics. Functional imperfections occur not only in the foot, but may have their origin in the superstructure, resulting in an often overlooked source of pedal stressors. Identification and neutralization of these osseous or soft tissue deficiencies is critical in the prevention and management of plantar ulcerations. Plantar pressure and temporal parameter analysis reveals and documents these abnormal, otherwise invisible forces occurring under the foot and inside the shoe while the patient is walking. So I've had my share. I see patients every day, and over the years, I've had my share of insensate feet. I've seen as many diabetics as anybody else, but I do not have my share of ulcerations. In fact, the last ulceration I can remember in my practice is probably 12 years ago. So they don't break down once I get them. And you can do the same. And other people say, well, you're lucky. I said, I am lucky. But I think it takes a little bit more than that. So here's Howard. And everybody's had patients like this. 80 years old, DM2, PN, peripheral neuropathy, hypertension, multiple comorbidities. He's active. He's never broken down. Pedal and superstructural deformity and dysfunction. No bueno feet. Even more revealing. You see the plantar-grade aspect of the talus. So that gives me a clue right away that it's not only excessively pronated, which you can see from the AP, but that there's some sagittal plane influences into this foot. And I'll show you in a second what else is going on. He has an inability to freely pass the body over the supporting foot. He can't sail easily over the supporting foot. And in order to do that, his foot has to break. And where does it break? It breaks at the navicular cuneiform articulation. And it's not a straight downward break. It's a downward inward twisting because the ground isn't yielding and the body is moving forward. So the opposite limb is moving forward, the foot is pressing down to gain passage over the supporting foot because of some limitation in the sagittal plane that's probably, which you'll see in a minute, is in the superstructure. And you see the met primus elevatus. So he's basically creating his rocker bottom foot. So this is a 15-year follow-up, 16 years actually. So I've seen Howard for many years. And in July 2009, when I first saw him, and most recently, I saw him in September of this year, but we didn't update his exam. His biomechanical examination, I update every 2 years. So I saw him in 2009. His foot was completely flat, off weight bearing. And after treating him and seeing him, I saw him in September of 2024, and his foot was medium to high arched on the left and higher on the right. That's from completely flat before. His initial diagnosis, besides all the comorbidities, he had sinus tarsitis left and peroneal spastic flat foot left greater than right. So his foot was held in a spastic flattened position, off and on weight bearing. And you can see the on weight bearing position. His hip joint ranges of motion were perfect before. So basically, he had a good suspension. And now, 15 years later, he has a stiff suspension, meaning that there's no adaptability for changes in the terrain or for pronatory influences that he has to adapt to. So it's not going to be a smooth ride for this individual. In the beginning, when I saw him, his hamstrings were almost 10 inches fingertips to toes. You should be able to touch your toes seated with the knee extended. And now he's 17 and 15 inches to his toes. That's partly because of the disease process, partly because of COVID, and partly because of activities that don't encourage lengthening of the hamstrings. His dorsiflexion was good to start with, in terms of if you had a perfect foot and a perfect superstructure, 10 degrees would be adequate. But he doesn't have that, so he needs a lot more than 10. But it's reduced from what it was, 10 and 13 degrees. His hallux dorsiflexion was 48 degrees on the left and 54 on the right years ago. Now it's 57, which was better, and 40 degrees. So he's stiffened up on the right side, but enough to get him going. He's not playing tennis. And so he's very active. He walks a lot. He goes to the gym. His subtalar joint range of motion was 20, 22 initially. Now it's less, 16 degrees. So again, you can't dissipate the shocks that are going into the system. And it's not only the impact, it's not only the level of force that's going to create the ulceration, it's the time in which it's applied in the gait cycle and the degree of shear which accompanies it. So how do you determine that? Well, you determine that by trying to find all the imperfections that are contributing to the pathomechanical function. So his forefoot varus was 25 and 33, measured in 2009. And today I measured 35 degrees, which is more, so there's some supinatus that's in there. So pronation begets pronation. And once you twist the foot into an abnormal position, it in a plastic manner, deforms to that position. So it retains that position. It will reduce if you negate the deforming force. But first you have to identify it. And the right was improved from what it was. So his overall collapse of his foot, total varus measurement, and I can send you articles on that too. So 44 and 60 degrees. Normal would be 0 to 10 degrees of deviation. And when we saw him 2024, his total collapse of his foot was 45, which is the same, and 50, which is 20% better. So overall, he's much better than he was in certain instances, but his foot is definitely, and extremities are definitely tighter. He came in 2009 with orthotics from another podiatrist, and they were graphite-type devices. And the total varus measurements in those devices was almost the same as without the devices. And he was wearing, in 2024, devices that I prescribed for him in 2019. He would go to Florida, and then he didn't come back for a while, so he was wearing a UCBL-type device that I prescribed in 2000, and the total varus measurement with that was 35 and 25, which was better than what he had. His right hip was lower, and it was lower again when we saw him. The angle of gait was 7 and 15 degrees abducted, and it was the same in 2024. The device that he was wearing in 24 that I prescribed in 2019 was a dynamic stabilizing inner sole system. And that is a UCBL, a functional UCBL with a slit in the middle. So why is this good? This is particularly good. It's designed for children. It's particularly good for anybody with sagittal plane deficiency because there's two independent arms to control the foot. So it allows them to adapt to it and accept the correction within a certain limit. So it was first designed by Schoenhaus and Jay, and there's an enhanced calcaneal inclination of 1/8 of an inch there, and you could see that there's a medial and lateral control arm. So when you need additional dorsiflexion because there's not enough for the body to allow it to travel forward, you can push down on the orthotic, the ground will push up and allow that medial segment or lateral segment to shift upwards to a point, but within a guided range of motion. And so I use this in adults and CP people too. CP patients, adults, it's an excellent controlling device. There's some limitations. You can't extend it forward because you need the slit to be able to control the foot. And you can't add a metatarsal pad. And it's prone to fracture. The forefoot post you can't extend, and you can see it's prone to fracture. So this is Howard. This is barefoot, 2024. You see there's a white line is the center of force pressure. There's a medial deviation of the center of force on both. And then three-dimensionally, you can appreciate that better. So how do you know this if you don't have something like this? Everybody that treats insensate feet or anybody that treats wounds, if the patient is ambulatory, they should have a system that determines this. And it's not just to step on a mat. This is after 26 feet of walking. So there's 6, 7, or 8 steps here. And it's the average of all those steps minus the first and the last steps. So, and then also, it's not enough to just look at pressure mapping on the foot. You need to look at the time in which it's applied, so you need waveform comparisons. So this is barefoot. This should look like a double hump curve, a double hump camel, heel and ball. Purple is the heel. All the other colors should be the front to the foot. So you can see, number one, they're not even. And number two, the heel's on the ground too long. And there's no dissipation of pressure on the front of the foot. If this person is prone to ulceration, it's going to be sub-first metatarsal if he continues to walk barefoot. And the first thing you should tell all these patients, no barefoot walking. No? Go to the bathroom? No barefoot walking. Shoes are always better than barefoot. Even bad shoes are better than barefoot. So stance and swing are usually even, especially in barefoot testing. And that's what people see when you're walking. The stance phase is broken up into 4 segments. And the important ones we're going to look at is mid-stance and propulsion. And under 30 is a good mid-stance. 18 to 22 is optimum. High school athlete. So he had 34 and 25, so it wasn't even. It was a third difference. His propulsion is greater on the right side, and his active propulsion was less on the left side. And active propulsion should always be greater than passive propulsion, or at least equal to it. So he took 108 steps a minute, so nobody said, whoa, you're limping, or things like that. And he moved well, so he was able to keep up with everybody else. But he had a 19% difference from the left heel to the right heel. Now that's too much. So here he is barefoot, but now watch. Here he is in his sneaker. No orthotic. So that's unbelievable. There's still medial distribution of weight. So there's still a problem. But you can't see this unless you can see this. And you can't look under the foot and inside the shoe while the patient is walking. So here's barefoot, and here's in his sneaker. You still see the medial distribution of body weight. So the whole weight of the body is going through there. There's barefoot, and there's in his sneaker. You see the forefoot. There's some propulsion in the forefoot. So there's some propulsion and a distribution of pressure over a broader surface area. So in sneakers, his midstance equals out. His active propulsion is still low. In fact, it's even lower than it was before because you have to go through the shoe to bring the body forward over the foot. 104 steps a minute, and he's even in terms of calcaneal stance duration. Normal's up to 62, but the shoes make you stay on the ground longer. So this is far better. So then I took a new cast of his foot, root suspension cast, in a neutral to supinatory position. And I prescribed a new UCBL DSIS. So I extended the medial platform because his foot is so broad, and I put a medial longitudinal arch pad on this as well. And I had to mail these devices, I had to mail these to him. That's why it's worn on the bottom. And he wore them for 6 months. And he came back, and we did his gait test. And this is his gait test. So there's a sneaker, and here's his sneaker plus the orthotic. And you see how, number one, you see how narrow his foot is? And also the equal distribution of pressure. He has pressure. It's 61 pounds of pressure. I can tell you how much pressure it is. It's 61 pounds of pressure in the mid-shaft of the first metatarsal. And why is that? It's not from the orthotic. There's the heel before. There's the heel with the orthotic in the same shoe. It's from the medial arm of the DSIS. He can't get any more motion out of it. But why does he need the motion? I'm going to show you. Here's his sneaker, and where you see the difference. Here's his DSIS. And you see the propulsion, the red is the hallux. So he's pushing off actively. And he has flat curves on the heel curves because he can't pronate anymore. So these devices hold him so well, he doesn't have any hip rotation to go along with the 4 to 6 degrees of shock-absorbing adaptation type pronation you need at heel contact. So what does he need? He needs PT. He needs increased hip joint ranges of motion. He needs hamstring stretching on a regular program. It's the hamstrings that are causing the problem. You could lengthen the gastroc from now until 50 degrees worth of lengthening, which is not good for the patient anyhow, but it's not going to help this. So here's his sneaker, and here's his DSIS. And that's basically the ridge against the side of the shoe, of the medial arm of the orthotic. Here's the forefoot in the sneaker. Here's the forefoot with the orthotic. See the even distribution of pressure. The forefoot in the right foot in the sneaker, and the forefoot in the orthotic. The heel, medial, and the heel, central. The medial arm of the device. is what needs to be addressed. Here's his sneaker. I showed you 4, 6, active and passive propulsion. And the heels, these numbers I'm going to show you now. This is Howard in the orthotics. 23, 23 mid-stance. Propulsion's 27, 26. Active and passive propulsion are even, essentially even. 118 steps a minute, and his heels are on the ground, 53, 51. This is what people in their 20s get. Is this successful? Yes and no. Because what's the problem? The problem are his hamstrings. The hamstrings, he can't pronate anymore, so he can't collapse his foot. So we have even weight distribution, but he doesn't have the play to go forward. So those hamstrings have to be stretched. Each inch that you get closer to your toes is the equivalent of 20 degrees of additional forward passage of the body over the supporting foot, which diminishes plantar pressures and diminishes the risk of plantar ulceration. So he needs to be stretched. If he can stretch, get 5 inches closer, that's 100 degrees with every step he takes. So that's what this person needs. But otherwise, he walks quickly and he keeps up with all his contemporaries. So in closing, it's been my experience based on careful observation and analysis, agreeing with reason and a benefit to all patients, that identification, documentation, and neutralization of functional or structural imperfections in the insensate foot, along with concomitant pathology in the superstructure, reduces the risk of plantar ulceration. Ladies and gentlemen, I wish you and your patients smooth sailing. Thank you very much.